All right, welcome to another episode of ICU Doc Talk. Thanks for joining me. It's been a bit since I put up an episode, but thanks for tuning in again. Today I'm going to talk about point of care ultrasound. So this is probably geared more towards medical people, but but if you're non-medical, you may enjoy what I'm going to talk about. So ultrasound, we all know what ultrasound is, right? When someone's pregnant and they go in and get their anatomy exam or whatever of their growing fetus, you put an ultrasound on the belly and you can see the anatomy, you can see all that using ultrasound waves. So an echocardiogram is an ultrasound. So there's many different machines, there's many different diagnostics that are used in medicine, and it's all just a lot of it is ultrasound, which are it's not X-ray, right? It's not ionizing radiation. It's not using radiation. It's using ultrasound waves, which are we believe are benign to your tissues, to take a look inside your body, right? So there's many different modalities. There's many different types of machines that we use to try to treat things like ultrasound guided aspiration of a breast cyst or something like that, right? There's lots of different uses of ultrasound. What I'm talking about today specifically is point of care ultrasound. So what does point of care mean? Point of care means like a practitioner has, I guess, my own definition here is probably not going to be that good, but it means using it clinically in the moment, like a point of care glucose check, right? You have like a little machine, a glucometer, and it's point of care. You use it right there clinically, and you get the result right away. So that's what point of care ultrasound is. So it's a highly useful thing for someone like myself. So I'm an anesthesiologist and I'm also an intensivist, a critical care physician. So I use an ultrasound machine to help me as an extension of my physical exam, to help me diagnose and to perform procedures in the moment clinically, right there. I'm not using my ultrasound like I'm using it and then I'm sending it off to a cardiologist or a radiologist to look at. It's me. I am the practitioner. I am using ultrasound to enhance my skills in the moment to then make decisions in the moment. That's what point of care means. So I'm going to talk about point of care ultrasound, how I use it, when I use it, and the limitations of it as well. So let's talk about that today. So in my role using ultrasound, I use ultrasound every single day. Right, in the anesthesia world, we use it to to put in like lines, right? To put in a central line, like an internal jugular line, like a central line is what we typically call that, which is like a big IV that goes into the vein of your neck that goes right down to very near your heart to infuse medications. So we use ultrasound for that, right? I use ultrasound in the operating room to place things like lines, to place arterial lines, to place IVs. Which, by the way, if you've ever done it, I say this to my residents all the time. I think putting a placing an IV with an ultrasound is one of the hardest things to do in the anesthesia world. It's harder than putting in a central line. It's a very nuanced technique that takes a long time to develop. Anyway, that's another discussion for another time. So I use ultrasound for that, obviously, for stuff like that. But I also use ultrasound for there's so many things I use it for. A cardiac exam, a basic cardiac exam. So let's start with that. I use ultrasound even more so when I'm in the ICU, when I'm in the unit, and particularly when I'm in the cardiac ICU, but when I'm in other ICUs as well, I use ultrasound. So here's a common scenario, and I'll get to the cardiac exam. Like, here's a common scenario. I have a patient who's in shock. They're in decompensated shock. They're on a bunch of pressors, and I think maybe they're in septic shock, right? So maybe they have positive cultures. Maybe they don't yet. Maybe they came into the emergency department and we don't have positive cultures yet, but they have a lactate that's through the roof, and they're in decompensated shock. They're on norepinephrine, they're on vasopressin, they're on epinephrine. Maybe they're intubated, and they're not doing well. You have them on broad spectrum antibiotics. You have them on stress dose steroids, and you're sitting there wondering. And here's always the classic question in critical care: is this undifferentiated shock? Meaning, is this just septic shock, or is there something else going on? Does this patient also have another class of shock that is contributing to their ongoing decompensation and clinical deterioration? So what I mean is, I want to find out if this patient has another type of shock. So if I'm suspecting, hey, this patient has septic shock, maybe they have cardiogenic shock as well. Maybe they have stress-induced cardiomyopathy, or maybe they have an underlying cardiomyopathy as well. A very, very simple thing I can do. I can order an echo, right? So an echo, echocardiogram is where you place an order for an echo, and an ultrasonographer comes, someone who is highly trained in using ultrasound, which I am not, right? Using point-of-care ultrasound, you are not an ultrasonographer, right? And an ultrasonographer is the top skills, right? They are extremely good at using ultrasound. Here's a comparison. So I'm like, I play the guitar, and love to play the guitar. I can also play the bass, but that doesn't mean I'm a bassist, right? So I may be a guitarist. I can play the bass, but I'm a guitar player playing a bass, like with a pick. I haven't learned how to play the bass properly, so I'm not a bassist. I'm a guitarist who can play a bass. So what I mean by that is, I'm not an ultrasonographer, but I can use an ultrasound, right? Same thing, like bronchoscopy, right? I do bronchs, right? Put a fiber optic camera down someone's, trachea to look at their lungs or clean their lungs out, right? I can do a bronchoscopy, but I'm not necessarily a bronchoscopist. I'm not a pulmonologist trained in bronchoscopy, but I can do bronchs. Anyway, I'm getting lost in my thoughts here. What am I even talking about? Oh yeah, so you're trying to differentiate shock. So in someone who's, I think, is in septic shock. So I put an ultrasound on their heart, and I look at their heart, and then I can be like, wow, I do think this patient has maybe they have cardiogenic shock. So what I mean is, yeah, I can order an ultrasound and have an ultrasonographer come and take a look, and then a cardiologist eventually take a look at that, what the ultrasonographer takes a look at. That's what Oregon Echo is. Point of care ultrasound is I put the probe on the chest, I look exactly what's going on, and I make clinical decisions based on that. So let's get to a basic cardiac exam. So this is geared towards, I'm gearing this towards people that are familiar with some of the language. So I'm going to use language that you may not be familiar with unless you've done ultrasonography a little bit, or you're in medicine. So you may not be familiar with the language I'm about to use, but I'll try to keep it to as broad of an audience as possible, which will be hard. So there's four basic views. When I do the same thing every time. When I'm putting an ultrasound probe on someone's heart, I do the same exam every single time in this exact same sequence. And I will tell you the exact specific things that I look for in each one of the views. So I try to get 4 different views with my cardiac exam. I start with the parasternal long view, right? Parasternal long view, you have the notch of and you use a phased array probe. That's important. The cardiac probe, it's square shaped. When you look front end at the ultrasound probe, it's square shaped. It's not a vascular probe. It's not long and linear. It's square shaped. It's called the phased array. It's the cardiac probe. You have to use that to look at the heart. So you have the notch, if you know what I'm talking about, the notch of the cardiac probe towards the patient's right shoulder. You have it facing that direction, and you go in between a rib, parasternal, right next to the sternum. That's why it's called parasternal long, and you're getting the long axis view of the heart. And what view are you seeing? You're mostly seeing the left ventricle. You're seeing a transverse parasternal long. You're not transverse. You're seeing a longitudinal cut of the heart, and there's many things I can look at in this view, but there's generally 4 things that I'm looking at. And I want to make something very, very clear. Because I'm not a cardiologist, I do not make quantitative assessments when I do point-of-care ultrasound on a heart. What I mean by that is I do not say, oh, this patient has an EF of 20%. I'm not qualified to make that determination. I make qualitative assessments, right? I say, wow, this heart looks like hell, right? Or this heart, oh, the function looks normal. Oh, this function is terrible. I make qualitative assessments, not quantitative. Now, I do a couple quantitative things sometimes that I'll talk about in a second that are very easy to do, but I'm not doing more advanced techniques and making quantitative assessments because I'm not qualified to do that, and I don't want to, do any overreach on my assessment. All right, so I'm looking at the left ventricle in this view. First thing I'm looking at is, does the left ventricle cavity, does it actually empty? Does it get smaller and bigger throughout systole and diastole, right? Because the cavity itself should be, during systole, it should shrink. The actual cavity, not the muscle, the cavity. And during diastole, it should enlarge. Look at it. Look at the chamber. Does it actually shrink? If it doesn't, there might be some poor function going on. It's not emptying properly. And then look at the myocardium. Look at the actual muscle itself of the left ventricle. is it thickening? Not just is it moving, is it thickening during systole? If it doesn't thicken, that myocardium may not be functioning well. It might be moving, it might be along for the ride. Some of the myocardium might just be along for the ride. But if it's not thickening, it's not participating in meaningful contraction, right? And then one of the other main 4 things, qualitative things I'm looking at, is the anterior leaflet of the mitral valve. Is that moving? And is it hitting the septum during diastole, right? It opens during diastole, right? The mitral valve. Is it moving robustly, or is it just barely opening that anterior leaflet of the mitral valve? That's a huge indicator of myocardial function. If it's just barely opening up and down, that's severely depressed ejection fraction. And then with that, you can do a calculation called the E-point septal separation, which is put the M. I swear I'm not going to get too much in this jargon. Put the M mode, if you're familiar with what I'm talking about, put the M mode through the mitral valve. And what that does is it measures the space between the mitral valve, the anterior leaflet of the mitral valve, and the septum. And if that's a large space, that means you are the E-point septal separation. That's what you're measuring. If that's a large space, I think it's usually 1.8 centimeters is the cutoff, but I would have to look that up again. If it's larger than 1.8 centimeters, that means poor function. Anyway, check that. Double check that on me. I think it's 1.8 centimeters. And then what else was I going to say? And then look at the mitral annulus. The mitral annulus is the ring surrounding the mitral valve. And what it looks like in the longitudinal view, it's kind of this pyramid-shaped thing at the very bottom of your screen. And if that's moving robustly, if it's swinging nice and back and forth, then that's good function. If it's barely moving, then that's a sign of poor left ventricular function. Okay, so I know that was a lot of jargony stuff. Obviously, it would be easier to teach you things if I was standing here with an ultrasound probe. And then a little bit of caution with this view, the right ventricle. You can see the right ventricle, and it's technically not even the right ventricle you're looking at the top of the screen in the parasternal long. What you're actually looking at, you're staring down the barrel of the RVOT, the left ventricular outflow tract. The reason that's important is in this view, the parasternal long, you cannot make a super meaningful observations of what the right ventricle is doing. In this view, you have to look at other views because you're looking at like a barrel of a gun, not a chamber. You're looking down. It's almost a transverse view of the RVOT. You can easily foreshorten that view and trick yourself into thinking the RV is huge when actually you're just looking at an oblique view of the RVOT, what can make it look big. So you have to be careful when you're looking at this, when you're assessing the right ventricular in the parasternal long view. Okay, and then what are you also looking at? You're looking at, hey, is there an effusion? And if there is an effusion, are we having major collapse of your chambers? You can't rule out tamponade in this view yet. You have to have a 4-chamber view to really rule out tamponade. But you're making note of other things. Sometimes in the parasternal long, you can also see the descending aorta right at the bottom of the screen. You can't always see it, but sometimes you can see it, and it's nice to note that. And I guess if you had a dramatic aortic dissection, you might be able to observe it in that view as well. There's more things to look at in this view, but let's go to the next view. So from that view, I twist the probe. So the notch was going to the right shoulder. Now it's going to the left shoulder. And you keep it there towards the base of the heart. I don't move it much. And now I'm looking at the parasternal short axis view. Now you're looking at a transverse view of the left ventricle and the right ventricle as well. And it should be mid-papillary. You should see the papillary muscles not kissing. They should be, if they're kissing, it means you're intravascularly depleted. But you should be mid-papillary. You don't want to be too much towards the apex where you're going to fool yourself into thinking that the left ventricular chamber is like too small or something. And you don't want to be too near the base of the heart where you're seeing the fish mouth of the mitral valve, right? You want to be mid-papillary. You want to see the papillary muscles. And here you can actually you're looking at the myocardium of the distribution of both coronary arteries, right? So you can actually look to see if there's a little dyskinesia, akinesia going on. Again, I don't feel qualified enough when I'm looking at this view to be like, oh wow, I think the PDA is out, right? One of the coronary arteries. Wow, I don't make those determinations, but I feel like I'm comfortable in saying this looks dyskinetic. This is not concerted. This is not a nice concerted contracting myocardium. There's something going on here, and maybe it could represent ischemia, or maybe not. I'm going to order an ultrasound, a formal echocardiogram to confirm. Right? These are the determinations I'm making. I'm looking at intravascular I'm looking at if the papillary muscles are kissing one another, or if, meaning, they're coming in, they're getting very close, or if they're nice and separated. This is a nice sign of if someone is intravascularly down or up, right? Or if they're underfilled. If the papillary muscles are like kissing, you can be like, wow, this patient needs fluid. In fact, I would say that looking at this view is more informative to you of someone's volume status than looking at their IVC, which I'm going to get to. IVC is a big thing, which I'm going to get to. So I'm going to talk about this a little bit more. This kind of jargon stuff, if you're not into this, I would skip ahead because I'm probably going to spend the next 10 minutes keeping in this kind of lane of jargon. If you're not familiar with this jargon and you're rolling your eyes, the next 10 or 15 minutes are going to be painful for you. So I would skip ahead. If you're with me, then just hang along for the ride. I'll talk a little bit more about this. All right, so the next view in the cardiac exam is the apical 4 chamber, because you're looking at all 4 chambers of the heart, and you have the probe at the apex of the heart. So this view is very good at looking at valvular dysfunction, mostly the AV valves, the mitral valve, and the tricuspid valves. Right? You can look to see if there's like how much significant regurgitation there is. And this is a very good view for looking at RV dysfunction. Remember, the parasternal long axis is the RVOT, but here in the apical 4 chamber, you're looking at you really can see the function of the RV. Is the tricuspid annulus moving well? And here, again, I won't spend too much time, but you can measure something called a TAPSE, a tricuspid annular plane systolic excursion, where you put M mode right through the tricuspid annulus, and you can measure how well that's moving. I mean, you can quantify that, and that can help you understand how well the RV is functioning. You can also look at the quality of the function, and then you can look at the the size of the RV. It should be smaller than the LV. It should look like a shoulder to the LV. If it is equal in size to the LV or larger than the LV, that's LV or RV distension. Now, you can have RV distension and normal function, right? So just because it's distended doesn't mean the RV is not functioning well. Could mean you just have, for whatever reason, you have pulmonary hypertension or your pulmonary vascular resistance is too high. So you have to look at both the quality of how well the RV is moving and if it's distended. So the apical 4 chamber is a great way to look at that. This is also a great way to rule out tamponade. Right, so just because someone has a diffusion, that may be inconsequential. Maybe that's not a big deal. It depends on the clinical context. Now, if you see an effusion in another view, then you come to the apical 4 chamber, and the first thing I look at, what chamber do you look at first? You look at the right atrium to see if someone is having tamponade physiology. Why? Because it is the chamber that is the lowest in pressure, and it's going to be the most sensitive to impending pericardial pressures that are acting like a vice on the heart. And you will start to see diastolic collapse of the RV first, right? That's the first chamber that will start to collapse during diastole. Just think about it. None of your atrium should not be collapsing during diastole. They should be full. They're pressurized because they're contracting, right? So during diastole, if they're collapsing, that means the pressure on the outside is the pressure gradient has flipped. It's because you have tamponade physiology. So that's the biggest sign. Now you can have RV diastolic collapse and now if you look and you have LV diastolic collapse, that person is probably about to go into cardiac arrest. So that is one thing that can rule out tamponade physiology. You can pair that with pulsus paradoxus, right? And sometimes on an echo report, an echocardiographer will or a cardiologist will call that respirophasic interdependency. Anyway, sorry, I know I'm getting way too much on the jargon here. Let's just move on. The last view I then look at is the subxiphoid or the subcostal view, which really shows you the RV at the top of the screen. That's what you're seeing closest to the probe. And it's just another really good way of characterizing the function of the RV, the quality of how well it's moving, how rigorous is it. And then from there, so in that position, you have the marker of your probe to the left of the patient. From there, I then go. I make the probe vertical along the body, and I focus in on the RA, and then I make it vertical, and then I look at the IVC, and then I do my IVC exam. What do I care about the IVC? So the IVC is lots of controversy, right? I could do a whole podcast just talking about the IVC exam. So here's a story. So one time I had like a resident who saw a patient in the emergency department, and they looked at their IVC on ultrasound. And this patient had a history of heart failure, And there was a thought that maybe the patient was hypervolemic, volume overloaded, and was in respiratory failure because they were in heart failure, which is a very common clinical presentation of CHF heart failure exacerbation. So the resident said, I did an IVC exam, and the IVC was normal. So I don't think we need a diuresis patient. And I was like, all right. So I went down and said to the patient, patient's floridly fluid volume. You just look at the patient, and you can see there's fluid everywhere, right? I mean, my finger sank halfway down to the patient's shin. My point of telling the story is you cannot hang your hat on a single IVC exam to make a determination about someone's volume status. The IVC is not reliable about volume status. Now, I do care about its extremes, right? Is it plethoric, meaning is it super enlarged, the IVC? Is it huge? Is it way more than 2 centimeters? Because that means their volume overloaded. Or is it super, super, super collapsed, like you can barely see it, it's collapsing, the sniff test is it's collapsing. And then maybe they're hypovolemic. Maybe, right? You have to pair that with a constellation of everything that's going on. It's the same thing with CVP, right? The CVP number is a representation of it's a quantifying your qualitative exam of looking at the IVC. It's the same thing. A CVP, it's all about a trend. You can't just hang your hat on any one value. And the extreme values matter more than middle of the road values. It's the same thing with evaluating the IVC. So when I look at the IVC, what am I looking for? Okay, is it plethoric? Is it huge? Is it super collapsed? And then when I'm looking at the IVC, I will look at the hepatic vein, which you can find fairly easily coming off the IVC, or I should say feeding into the IVC, right? The inferior vena cava, right, is what IVC stands for. And put some Doppler on the hepatic vein. And if you're having reverse flow, if the flow is not going towards the IVC, but if it's going towards the liver, that's, hepatic vein reverse flow, that's a sign of volume overload and RV overload, and that your RV may not be functioning very well, right? Because the flow should be going the other way. Anyway, so that's kind of how I do my basic cardiac exam. And you can do all these things, right? All these things I just talked about. You can do this all in 3 or 4 minutes. Now, some people have limited ultrasound windows, and you can't really see that well. Sometimes you need to order a transesophageal echocardiogram, which I also do. I'm not what's the word? Certified in that, but I will also do a TEE as well as an extension of my physical exam. Anyway, okay, and then so let's move away from the heart, and now the lungs. Okay, let's see what's the story. I mean, there's many stories I can tell. So one of the main reasons you do an ultrasound on the lungs is so you can look for pulmonary edema, right? There's something called rocket lines or B lines. And now pulmonary edema, you often can see on a chest X-ray. I'm usually not grabbing an ultrasound to be like, how much pulmonary edema does this patient have? I usually have a pretty good idea if someone already has pulmonary edema. One of the reasons I'm looking at someone's lungs is to rule out a pneumothorax, right? A collapsed lung. And it's highly sensitive to ruling out a collapsed lung, a pneumothorax, more than even a chest X-ray. Now, I personally like to use a vascular probe when I'm looking. A lot of people use the phased array cardiac probe, but I like to use the linear vascular probe to look at the lungs. And you look at lung sliding, right? You look at the pleura. And obviously you can YouTube video all this stuff that I'm talking about. It's hard, if you're not familiar with the things I'm talking about, this is probably rough listening. But I like to use the vascular probe because I feel like the pleura is closer to the screen. It's enlarged and I can see it better. So you look for lung sliding. You look at the pleural. Does it look like it's glistening? Sometimes it's described as ants marching on a line. And then you can put M mode through that. So M mode, right, takes basically a bunch of pictures, and then lines it up, and then shows it to you like linearly, like what happened over time with this structure. How did it move? That's what M mode is. And if the pleura is moving, M mode, it looks like a sandy beach. If it's not moving, it can look like a barcode, right? Again, Google these things if you're not familiar with them. Or just keep hitting that that forward 30-second button, because what I'm talking about is driving you crazy because you don't care. Whatever kind of listener you are, that's fine. So that's usually how I'm using it. Now, you have to do it in multiple lung fields. You can't just do it in one lung field in each lung and be like, they don't have a pneumo. No, you got to do it in multiple, like 3 lung fields per lung, right, to rule out a pneumothorax. So that can be extremely useful in that setting. Okay, so here's another story. I had a patient who came up who was crashing overnight on the floor. A rapid response was called. We brought him to the ICU. There was clearly something wrong with him. They're in some sort of decompensated shock. Didn't quite know. They had a surgery earlier that day, but it was a long time ago, and it wasn't clear, like, why would the surgery... Anyway, we're like, maybe they're bleeding. And I put a ultrasound probe. I did a FAST exam, which, what does that even stand for? I forget what FAST exam stands for. Sometimes abbreviations, you use the abbreviation so often and for years, and then you never actually use what it stands for, and you forget what it stands for. What does FAST exam stand for? It's I'm actually looking it up because I'm forgetting. One sec. All right, it's a focused assessment and sonography in trauma. Okay, so FAST exam is basically a 4-point exam where you look at around the bladder. You look at see if there's bleeding around the bladder. You look at if there's bleeding on left and right abdominal signs around the kidney and liver and the spleen, and then you're looking at, and then you're doing a cardiac exam with that. So that's a FAST exam, and you're looking for in the belly you're looking for free fluid. And anyway, so I took a look at this patient, put a probe around around his abdomen, and I saw on the right upper quadrant there was just a bunch of free fluid. And I was like, this patient doesn't have a history of liver cirrhosis, doesn't have a region of ascites. I'm pretty sure this is blood. I think this patient is bleeding out. So we resuscitated the patient with blood and did that for quite a bit. And they had to have an exploratory laparotomy with surgical repair of a mesenteric bleed. Anyway, my point is that's what part of the FAST exam is. It's a highly valuable part of using ultrasound. It's obviously used in the emergency department, often in trauma, to rule out bleeding, but I use it all the time. Now, what about using ultrasound during a code blue or a cardiac arrest in the United States? Absolutely. So if I'm coding someone and we're resuscitating, we're doing chest compressions. Now, there's different types of codes, right? Some you get ROSC, return of spontaneous circulation, after a round or two, right? Maybe they had a malignant arrhythmia or something like that, and you got them out of it, and you go from there. Sometimes it's going 8, 9, 10 minutes, and you're like, I don't know what's going on with this patient. Now it's around that time that I'm like, I want to see you an ultrasound. I want to get an ultrasound and see what's going on with this patient. So the way when you do an ultrasound, and I'm talking about doing a cardiac exam here, and a FAST exam, doing a FAST exam during code blue, but I'm often interested in the cardiac exams, oftentimes. And you do it, you have someone ready, oftentimes I am doing it because I'm the only person in the room that can use an ultrasound. Sometimes I don't have a fellow or anybody with me. But if I do have like a critical care fellow, I have them hold the probe at the subxiphoid position while the chest compressions are going, and during the pulse check, when you stop chest compressions, then you do the exam. You look at the heart. And what are you doing? For one thing, you're looking at, what are you looking at here? You're looking at myocardial activity. Is the heart moving at all? Like, that can be useful information. Sometimes it's like completely akinetic, and you're like, that's bad. And now, is that the reason that they had cardiac arrest? Maybe not. Maybe it's just stunned because they have bad flow. They have low flow during resuscitation. But you can look at the RV function. You can look at RV overload. Maybe you can be like, maybe the patient's having a PE when you've ruled out everything else, and maybe you need to push TPA. Right. And now I've pushed TPA during a code before. I've done it several times. The only time I do it, now this is just an aside, the only time I really do it is, and what I recommend to pushing TPA. For those that aren't familiar, TPA is a clot busting medication that literally breaks up clot. So when you have like a pulmonary embolism, like a blood clot that goes to your lungs that causes someone to cardiac arrest, sometimes the only way of getting them out of that is giving TPA to bust up the clot. It's a dangerous drug. You got to use it judiciously because it can cause stroke, it can cause bleeding. It's a powerful drug. Now, the only time that I give in a code is when we're doing resuscitation. I've gotten labs. I've ruled out a bunch of stuff, right, that have not caused the code, like they're not hyperkalemic. They're not bleeding. They have a normal hematocrit or a normal hemoglobin. And I really don't know what else is causing it. And then I think of the risk factors, like, do they have cancer? Do they have they been on VTE prophylaxis for clots? I think about these things, and I'm like, is there anything else that can be going on that's causing this? Oh, I'm 20 minutes into this code now. And then I'll give it, and then I'll push it. Oh, and then I'm like, are they going to bleed if I push it? Is it a contraindication? Do they have surgery? Sometimes our surgeons are right there, and I'll discuss it with them briefly. I'm like, I might push TPA. Do you have a problem with that? I'm like, well, usually they don't, because they're like, well, the patient's going to die anyway. And, you push the TPA. And I have gotten people back from it before. It doesn't mean they lived after. It doesn't mean that they left the hospital alive. Anyway, that's my little aside about TPA. Anyway, there's much more to say about ultrasound. This has been another classic rambling thing by me. I don't know if it's been helpful. Google all the stuff I talked about. My whole point is ultrasound is a definitely, it's an extension of your physical exam. You should become proficient in it depending on what specialty you're in. And I have used ultrasound countless times at this point, have recognized things earlier, have caught things earlier, have intervened earlier for a patient, and have helped patients. So it's definitely a skill that is becoming more and more important at point of care ultrasound. And I think all anesthesiologists should be good at it. I think it's imperative to be an intensivist and be proficient with point of care ultrasound. And you don't have to be certified. I'm not certified, right? You can go take an exam and get certified, blah, blah. I've taken the time to do those things, but I have taken the time to learn on my own. I did it through residency and fellowship and through my career to get good and comfortable with point of care ultrasound. And then the main point is don't overreach with your conclusions. I can't tell you how many times I think I've seen something bad on my cardiac exam, and then I get a formal echo, and it's not there. The bad thing is not there. So I often doubt myself when I think I see something bad, and then I got to confirm it with, people who really know what they're doing with an ultrasound. So that's happened many, many times. But again, I have caught things. I've caught badness with point of care ultrasound. So I encourage you to, if you're a medical student listening to this or a resident, it's up to you to really learn. Some residency programs might have, and fellowships might have some sort of curriculum. Depending on where you're at in the United States, they might have some sort of curriculum to help teach you, but it is up to you to learn. You have to put in the work. You have to go see patients over and over and over again and practice, and read books about it. It is up to only you, basically, to develop these skills about point of care ultrasound. It is a vital skill in critical care medicine and anesthesia. All right, anyway, there's much more I could have talked about with point of care ultrasound. It's a huge topic. But let's move on to a book that I have read recently. I listened to the audiobook of this. It's called The Road to Unfreedom by Timothy Snyder. It was published in April 3rd, 2018. It's about 359 pages. I enjoyed this book. It's got a lot of criticism that I've seen back and forth, which maybe I'll talk about a little bit. But for me, this is one of the best books I've read in recent memory about not only what fascism is, which almost at this point I don't even want to use the word fascism anymore because it's taken on this double think quality where it means whatever someone wants it to mean in the moment of whatever they want to criticize. Anyway, but the way I'm defining fascism here is mostly like one-party rule dictatorship. Anyway, this book really it talks about how it operates, how fascism operates, modern fascism. And the resurgence of like old fascist ideas and strategies, and how neo-fascism influences modern day politics, which it very much does at this moment. About half of the book, Snyder covers recent Russian history from the collapse of the USSR in 1991 to Yeltsin and then Putin, and then the rise of the Russian oligarchs who have become what he refers to as schizo-fascists, who are fascists themselves, but decry fascism to create a state of unknowing. So a classic thing of neo-fascists is to mold a narrative for whatever the political moment demands to keep you in control and to blame things on whatever else, a third party. Central to the book is the concept of political inevitability, the belief that something like democracy or global capitalism, free markets, whatever, is inevitable. And if we give it enough time, it'll all work out, right? That's political inevitability, which is the first time I'm hearing it from this author. And I think is an interesting idea. It political inevitability helps to reinforce kind of nationalistic pride, right? It's been used as an excuse in the past by prior American administrations to basically commit war crimes in, like, namely Iraq and Afghanistan. Political inevitability. Democracy will spread, right? Which obviously the United States doesn't really spread democracy. Like, it doesn't. it demonstrably does not spread democracy. It spreads the opposite. That's a topic for another time, and many other books for another time that I can talk about. But the United States does not spread democracy. It spreads hegemony, U.S. hegemony rule. Anyway, so in this book, as opposed to political inevitability is this concept of political eternity, that the current state of power is one eternal round that will never change. Political inevitability, like, oh, our enemies will always be our enemies. We will always be struggling against this thing. So inevitability blinds us to the reality of power, and eternity binds us with the belief that nothing could ever possibly change. There's no reason to try, right? It's like the politics of eternity are kind of like the politics of nihilism. So Russia, and when I say Russia, I mean the government. And when I say the government, I mean the one-party rule of Putin, who is a dictator. So he has perfected these politics while he basically runs down a broken-down oligarchic dictatorship. So because the current corrupted power structure cannot make things better for their own people in Russia, this is what Snyder argues, and fearing the dissemination of actual democratic principles in his own population, Putin has exported his own brand of fascism, especially to the United States, and has made everything worse. And Putin and Russian oligarchs have absolutely triumphed the last at least 10 years. Putin, who's heavily influenced by a xenophobic monarchical philosopher named Ilyin, which Snyder talks about a lot, seeks to destroy the European Union and the United States and to create his own version of Eurasia, which is like his own version of European Union of Eurasia, where obviously Russia controls it. Snyder takes a very deep dive, not a deep dive, but a good dive into the history and politics of Ukraine and the inevitable invasion of Russia, who has always seen the Ukrainian people as a possession of Russia. Always, right? Ever since the Muscovites 200 years ago. Kiev and Ukraine throughout World War II and throughout Soviet Union rule, Ukraine has been, along with Poland and the other Baltic states, has been a country fraught with conflict, war, and many powers that are struggling to control its sovereignty. And that nothing has changed till today. Russian propaganda portrays Russia as a nation of virgin innocence, where fact has no bearing, and anything against Russia is evil and must be destroyed, right? So there's doublespeak and doublethink, calling truth lies, and the opposite, fetishizing a fictitious mythic past. These are all in the toolkits of a fascist. Russia wants to make an empire of Eurasia that is anti-Semitic, anti-homosexual, and anti-West, and they have many tools and allies, including Le Pen of France, which Snyder mentions in this book. So you flash forward to who Snyder argues is a Russian puppet, Yanukovych, the prior president to Zelensky, who was democratically elected, but Snyder asserts that these were not fair elections and that Yanukovych was a puppet of Putin, which I do think, I'm not knowledgeable enough to refute that, but I do hear a lot of pushback that that's an American propaganda thing, to say that Yanukovych was a Russian puppet of Putin. Now, it's very much within the U.S.'s playbook for the CIA to fabricate coups, right, throughout the last 100 years to topple democratically elected leaders, particularly in communist or communist sympathetic countries like Indonesia and Chile and Venezuela, like all over the place, right? Cuba, all over the place. And people are arguing that this has happened in Ukraine recently. Now, I don't know if that's true. I don't doubt it, but I don't know if that's true. Anyway, so this book goes into Paul Manafort, who was part of Yanukovych, who also later became Donald Trump's campaign manager, who faced charges for perjury and other things. And then you have the Russian cyber attacks influencing the 2016 U.S. presidential election, which is irrefutable that has occurred. I won't go into the details, but Snyder does a good job with it, and there's other books that do a good job with that. All these things are related in very direct ways. There's a specific reason Donald Trump didn't want his tax returns revealed, likely. He was very, very likely bankrolled by Russian capital. Very, very likely, in my opinion. The evidence for these claims is pretty good. The result is that you have a Russian oligarchic kleptocratic style rule, which has been exported to the U.S. and has destroyed even further, our political landscape, which was already on the, terrible to begin with. So what's the result? You have mass disinformation, widespread political turmoil, this post-truth era, paramilitary groups. You have diseases of despair. You have race-based outcomes of health and wealth. You have a breakdown of social cohesion and then a literal insurrection. So make no mistake, this is what fascism looks like. This is what it is. I don't care however else people want to dress it up. I don't care. People love to make excuses for the ideologies. There's something interesting going on with the Ukrainian war. There seems to be an overlap between Americans that hate the Democratic Party and Americans that are against American-style global capitalism and the proliferation of it. There's an overlap. These two groups, okay, people that hate Democrats, which is a lot of people, and people that basically hate American hegemony, they blame the United States for the Russian invasion, for Putin invading Ukraine. Both these groups of people that are quite opposite, right? These are very different groups of people, but they both are almost sympathetic towards Putin and Russia. And it's interesting that the ideology and influence makes people come to this conclusion, right? I see the argument that the United States is responsible for the invasion, Russia invading Ukraine, which, in my opinion, is absolute nonsense. And what people say is, oh, well, they've been trying to force Ukraine and the other post-Soviet countries into NATO. Well, okay, that's fine, and yeah, that could be seen as an aggression, but that argument is predicated on the assumption that those countries are appendages of Russia and don't have sovereignty. I don't think people realize that that's what they're saying. When they say that the U.S. has been aggressive by trying to get those countries to join NATO, they're assuming that these countries are still, in a way, part of Russia and it threatens Putin, and so he was forced to invade Ukraine. Nonsense, okay? That's nonsense. Anyway, what do I know? I don't know much. These are just my opinions. Take it or leave it. Anyway, I thought this book was good. The Road to Unfreedom by Timothy Snyder. Check it out. Anyway, that'll be it for today. Email me at icudoctorecmo@gmail.com. Follow me on TikTok at icudoctor. See you next time.